during their ventilatory stay when their lung pathology is not improving. And at that time, we have to understand the ventilatory graphics very well so that we can optimize our ventilatory setting and prevent the ventilator-induced lung injury. And in this regard, our next speaker will come into action. It is welcome Dr. Kanwalpreet Sodhi from Ludhiana, India. Madam is DNB in anesthesiology after doing her diploma, and she has also passed IDCCM and European Diploma in Critical Care Medicine. She is presently working as a director and head of critical care in Deep Hospital, Ludhiana, India. Madam is also the editor of ISCCM Manual of Renal Replacement Therapy and ECMO, which is an excellent reference textbook for the practicing intensivist. She is also the editor board member of Journal of Anesthesia and Clinical Pharmacology. She is an ISM accredited teacher in critical care, also an ALS, ACLS and BLS instructor and FCCS course instructor. Ma'am has also contributed in different textbooks of medicine and critical care, and she has more than 20 publications of national and international stature. Her areas of interest are nephrocritical care, ventilator, resuscitation, sepsis, and obstetric critical care. And Dr. Kanwalpreet will take us through the understanding of Weaning process of ventilator graphics so that we can manage our patients better. Welcome, Dr. Sodhi.
Thank you, Dr. Sudipta, for a nice introduction. At the outset, I would like to congratulate Dr. Saad and his team for such a wonderful platform they are running for this learning in anesthesiology and critical care. And thank you for bringing me here in front of you all. Well, we are dealing with the ventilators day in, day out. And it's such a usual thing for all of us. But why talk about the ventilator graphics? As Dr. Sudipta was saying, that weaning comes at the end. But what is important is how we deal with the ventilators, what we are doing with the ventilators, and how we learn about the ventilators. This is what the graphics about. Graphics are basically what we look at the ventilator interface. That is what is being shown by the graphics. Just a minute. So graphics are basically the mechanical interaction between the ventilator and the respiratory system. The waveforms, they provide an immediate feedback of the patient-ventilator interaction, providing a real-time info, like what is there happening to the patient who is being ventilated. Waveforms can give a clue into the abnormalities at a much earlier stage rather than before the clinical presentation is there. Actually, the analysis of ventilator graphics may actually play a significant role in the optimization of the patient-ventilator interaction as such. So why do we want to look at the graphics? We are day in, day out looking at the ECG, the monitors. So once we are ventilating the patient, we must look at the graphics. And we ought to have an in-depth knowledge of what they tend to tell us. Basically, graphics are aimed to reduce the complications associated with mechanical ventilation, such as patient ventilator asynchrony. We can assess the respiratory mechanics in mechanically ventilated patients and identify and per se treat the issues related to the respiratory mechanics. Well, the graphics, they're displayed in the two formats, the scalars that are the waveforms and the loops. And the waveforms which we can look at on the ventilator interface are the pressure, flow or volume versus time, and two types of loops, that is the pressure volume loop and the flow volume loops. There are basically 6 steps for interpretation of ventilator graphics. We have to identify the type of breath, differentiate the pulmonary measurements, interpret the ventilator plots, identify the displayed images of common modes of mechanical ventilation, interpret inspiratory and expiratory graphics, and identify signs of asynchrony. But these are very theoretical things, actually. What I want all of you to learn in these next 20 minutes is what are the basics of ventilator graphics, how we are going to deal with them standing on the bedside of the patient, and how we can improve the management of the patients per se using these graphics. Well, before we go ahead with the graphics, we should know that basically we have the 3 forms of waveform shapes. They're the square waves, which represents a constant set parameters that We have set the constant parameters and the wave is what looks like this, the square wave. Then we have the ramp waves, which represent a variable parameter and they'll vary as per the lung characteristics. The changes in the lung characteristics will vary the ramps. We can have an ascending ramp sort of thing. We can have a descending ramp waveform. We can have the exponential rise or the exponential decay. And the third form of waveforms are the sine waves, which usually are seen with the spontaneous or what we term as unsupported breaths. So based upon these shapes, in the pressure time, the flow time, and the volume time, waveforms will differ. The types of ventilation waveforms, they basically vary with the modes being used for ventilation. The pressure, whether we are using the pressure modes of ventilation or the volume modes. And as per the mode of ventilation, the graphics will vary, which we'll try to understand one by one in the coming slides. What is common to all these scalar waveforms are there are two phases. We have an inspiratory phase, which is the active phase and basically affected by the mode of ventilation, and the expiratory phase, which is passive and not affected by the mode of ventilation per se, but it depends upon the characteristics of the respiratory system, like what is the resistance, the compliance, what are the lung mechanics, and based upon that is the expiratory phase. So coming on to the waveforms one by one, we come to the pressure time waveform. Basically, if we look at the pressure time waveform, the pressure is on the y-axis and the time on the x-axis. So once we start, this is the start of the inspiration, reaching a preset pressure, that is the peak inspiratory pressure, and then a plateau phase comes, and when the expiratory valve opens here, the expiration starts and the waveform comes back to the baseline, depending upon either the baseline, if there's no PEEP applied, but if I've applied the PEEP, the waveform will come, the expiratory line will come over here as per the set PEEP. This is the pressure mode. What we can see, the pressure time curve on the volume control mode is this type of graphic, wherein there is a rise in the pressure during the inspiration, which will depend upon the preset tidal volume and how much pressure we reach to reach that preset tidal volume. And then there's a sharp rise in the pressure, which we term as the P plat or the plateau pressures, and then the expiratory phase. So now how these pressure time curves can be applied clinically. This is what we ought to know and what we are going to use day in, day out. The applications, they can be used to distinguish the breath type. We can use it to set the flow rates, the plateau pressures, the lung mechanics we can understand, and we can look at the rates, what we have said, are they adequate or we need to increase or decrease the respiratory rate set on the ventilator. So what is happening here? In the first breath, if we look at this, what is this? This is the triggered breath. And what is happening? The ventilator is actually assisting the breath. So on the pressure time graph, if we get this sort of breath, we come to know that this is the assisted breath and this is the controlled mode. There's no negative deflection at the beginning of the inspiration here. Then looking at the inspiratory line, if it's a straighter line, the flows set are adequate. But if we have the scooped out line, somewhat like this, the inspiratory flow, that means the flows set are too low and we need to readjust the flow rates. So this is how the pressure time curve can be used to assess the flow rates. Similar is the situation here. We have the scoop type of inspiratory curve, and it again tells us that air starvation is occurring and we need to reset the flow rates, or we need to increase the flow rates on our ventilator. Then in the volume mode, we talked about the peak inspiratory pressure and the plateau pressure. But what does this indicate? Why are they so important? They tell us the difference between the peak inspiratory pressure and the plateau pressure is what is the airway resistance. And we ought to know if we have a sharp rise in the peak inspiratory pressure with the plateau pressure remaining the same. That means we have an increased airway resistance occurring in our patient. What if The peak inspiratory pressure has risen, but the P flat has also rising. And this implies that the difference between the peak inspiratory pressure and the P flat is almost the same. So rise in P flat implies that there's a decreased compliance of the lung. So we need to look at the compliance component. Then pressure time graph can also be used to look at what is the auto peep, measuring the auto peep. Once we apply the expiratory breath hold at the end of expiration, we apply the expiratory breath hold, and then if this line is not on the baseline, this implies that there is a component of auto peep in our patient. Like this is the baseline. This is the peep which has been applied at the start of inspiration. This is the inspiratory limb. This is the expiration has started. And once we apply the expiratory breath hold here, this line should be on this if there had been no auto peep. But this graph is going like this. So the difference between the peep and this line is the auto peep. So the total amount of peep will be, this is the peep we have set, that is the machine peep, and this is the peep, which is the intrinsic peep or the auto peep. So total peep is this much in our patient. So we can measure the auto peep from our pressure time curve. Then what is happening here? In this breath, the inspiration and the expiratory wave. Okay. What is happening here? This is the inspiratory limb and this is the expiratory limb. But before the expiration ends, the next breath has come. So the next breath has actually started before reaching the baseline. So what is this? This implies that we need to increase the expiratory time for our patient. That means we need to modify the IE ratio, or we need to decrease the respiratory rate in our patients such that we give adequate time for this expiration to complete and the next inspiration cycle to start. Okay, now we come to the flow time curve. In the flow time curve, the flow is again on the y-axis. Time always remains on the x-axis, right? So flow and time. So in the pressure mode, during the inspiration, the flows increase, and during the expiration, the flows are negative, right? So reaching a peak inspiratory flow and a peak expiratory flow. So this is how the flow time curve looks on the pressure mode. On the volume control mode, the inspiration is more of a square wave, wherein the set tidal volume has reached, the flow has increased, and after achieving the set tidal volume, there occurs a plateau phase, and then suddenly the flows decrease once the expiratory valve opens, and then we have the expiration wherein there are the negative flows. So how the flow time curves can be used in the clinical practice? We can assess the breath type again, the auto peep, the airway resistance, and the bronchodilator response in the patients with airway resistance. What is this showing? This is showing that the inspiratory curve is having these dips. This shows that there are the patient efforts which imply that the flow rate set is not adequate. So we need to improve the flow rates. Okay, so now looking at this is the normal inspiration and the expiration. But what occurs here? In this, the expiration has been prolonged and it is not touching the baseline. So what is this basically? This is air trapping, or what we term as the auto peep. The next breath has started before the expiration has reached the baseline. So this implies, if we look at the flow time curve and we have this sort of graph, rather than reaching here, the inspiration is starting from here. This implies that auto peep is occurring in our patient. Okay, so this is another thing. Normally, the expiration is short in most of the patients. But if the expiration is prolonged, like what is occurring here, a more flatter expiratory curve, this implies that there is airway obstruction. The peak expiratory flow rate has decreased and there's a more broader expiratory curve with a longer expiratory time. So this implies the obstructive airway disease. Now in this patient, if we want to observe the bronchodilator response, we are applying the bronchodilators here. So this is the normal inspiratory and expiratory flow time curve in a patient with airway obstruction. So what should happen? So after the bronchodilator, what happens is the peak expiratory flow rate should increase and there should be a shorter expiratory time with a sharper rise in the expiratory curve. So this is what is termed as the adequate bronchodilator response, an increase in the peak expiratory flow rate, and the expiratory curve should return to the baseline sooner. Okay, coming to the volume time curve. So in the volume time curve, in the pressure mode, the volume, once the inspiration starts, to achieve a set target pressure, certain amount of volume is achieved, that is the tidal volume. So inspiration, this seems as a mountain type of curve. Inspiration phase and then the expiratory phase, wherein after the end of expiration, the volume ends up here. So this is the inspiratory time, this is the expiratory time. The volume time curve in the volume control mode would look something like this, wherein we achieve a set tidal volume and then there's a plateau phase and then the volume starts decreasing in the expiratory phase. So again, how does this volume time curve help? We can assess the breath type, the air leaks, or the active exhalation. Breath types we have already talked about. What is happening here? This, what is this? This is the air leak. The volume in the expiratory limb is not reaching the baseline. So this much amount of volume we have lost. So this is the air leak, and we have to look for like where the air leak is happening, right? Now what is happening here? The expiratory limb is going beyond the baseline downwards. So this is the active exhalation that is occurring in the patient. Now coming to the loops, the pressure volume loops and the flow volume loops. Okay, let's talk about the pressure volume loop first. In the pressure volume loop, the pressure is on the x-axis and the volume is on the y-axis. So once the inspiration starts, the pressure and the volume both starts increasing and reaching a peak inspiratory pressure. And then during the expiration, the pressure and the volume both decrease and come back to the baseline. This slope of the pressure volume loop, it tells us about the dynamic compliance of the system, the lung, right? So pressure volume loops, they are having a lot of applications. We can come to know the breath types. We can diagnose the airway obstruction, whether during inspiration or during expiration. We can tell about the respiratory mechanics, especially the compliance of the lungs and leaks, flow starvation, all things we'll discuss one by one. Okay. So first of all, the breath type. What is occurring here? This is a negative pressure during inspiration and a positive pressure during, slightly positive pressure during expiration. So this is the clockwise movement of the pressure volume loop. This is what occurs in the spontaneous breath. And if we apply the CPAP to the spontaneous breath, what occurs is this loop, it basically moves to the right, that is towards the positive side, since we have applied a positive pressure. So the clockwise direction of the pressure volume loop, clockwise movement, it always signifies that it's a spontaneous breath. Okay. Now, if we talk about the controlled breath, this is the inspiration. We have applied a controlled breaths are always positive pressure breaths. So we apply a positive pressure, and this is the inspiration, and this is the expiration. And this is an anti-clockwise movement of the pressure volume loop. And this is always a controlled breath, right? And what if we apply the PEEP? The same loop, it basically turns towards the right with a set amount of PEEP on the pressure increases. Okay. So what is occurring here? This is a negative deflection, that from clockwise to anti-clockwise. So this is a triggered breath. And this implies that there's increased work of breathing, and this certainly tells us that we need to look into the trigger sensitivity, and we need to reset the trigger in our patient. So whenever we have a negative deflection first and then a counterclockwise movement of the pressure volume loop, we ought to look at the triggers which we have set for the patient. Very important thing which the pressure volume loops tells us about, the work of breathing. The inspiratory limb and the expiratory limb. The inspiratory limb and this slope, the distance between the inspiratory limb and the slope, this is the resistive work. This signifies how much work is to be done to overcome the resistance in the lung. And the expiratory limb and the loop, this slope, it is the resistive work to be done by the lung. So this tells us about the work of breathing. And similarly, if there's an increase or flattening of the curve, the same pressure volume loop, if it gets flattened on the inspiratory side, this tells us about the inspiratory resistance, which can be because of the tube blockage or kinking of the tube. And if the expiratory limb is becoming more flattened, this tells us about the expiratory resistance. So we must look into these components once we have this type of flattening of the pressure volume loops. Okay, inflection points, another very important thing which the pressure volume loop tells us. The peak inspiratory, we have talked about that this is the inspiratory phase, this is the expiratory phase. And this is the upper inflection point and this is the lower inflection point. Once we look at the pressure volume loops, we ought to know what are the lower and the upper inflection points. Why are they important? Lower inflection point is very important because we set the PEEP as per the lower inflection point. And upper inflection point is for the plateau pressures. Okay. Knowing the lung compliance, this is a normal pressure volume loop in a pressure mode. So to achieve a preset pressure, certain amount of tidal volume is achieved. What happens here? To achieve the same preset pressure, the tidal volume achieved is much lesser. So this tells about the flattening of the curve in the pressure mode. The pressure volume loop, if it is flattened, this tells us that the lung compliance is massively decreased. And if at all, there is a rise, the steep rise in the pressure volume loop, upward movement. This tells that to achieve the same preset peak inspiratory pressure, the tidal volumes achieved are much higher. So this can happen in the emphysema of the lung or many other conditions. So the lung compliance has actually increased. So the flattening of the pressure volume loop in the pressure mode tells us that the lung compliance has decreased. What about the volume mode? In the volume mode, we have to achieve the preset tidal volume. So that according to the set tidal volume, a certain amount of pressure is achieved. There is a peak inspiratory pressure. What happens if the lung compliance is decreased in the volume mode? So what will happen to this pressure volume loop? This will turn towards the right, a rightward shift, because to achieve the same tidal volume, a higher pressure has to be achieved. So this pressure volume loop turns towards the right. And if at all the lung compliance is increased, there's a leftward shift of the pressure volume loop in the volume mode. This is very important to know and understand the compliance of the lungs. Okay. What is happening here? This is the normal pressure volume loop. What is happening here? With a very little change in the tidal volume, the pressure has massively increased, right? This was a normal pressure volume loop. And beyond, once we increase the tidal volume, there was no change in the tidal volume, but the pressure inside the alveoli has massively increased. So this is what is known as the overdistension of the lung alveoli. So this is what we term as the beaking of the pressure volume loop. So beaking of the pressure volume loop, it is very clear that overdistension is occurring. Okay. So what is occurring here? This is the inspiratory limb, this is the expiratory limb, but this is not touching the baseline. So certain amount of volume is lost here. So this is again a air leak occurring in the system. What is occurring here? This is the normal pressure volume loop. Now, what if this is a scooped inspiratory limb? This again shows that cupping of the inspiratory limb shows us the insufficient flow is there, and we need to modify the flow. We need to improve upon the set flow rates in our ventilator. Okay. Coming to the flow volume loops. In the flow volume loops, the flow is on the y-axis and the volume on the x-axis. So what occurs during the inspiration? The flows increase, the volume also increases. We reach a peak inspiratory flow rate, and then once the expiratory valve opens, the expiration starts, and after reaching a peak expiratory flow rate, the flows, there's a negative flow certainly during the expiratory limb, and the volumes reach back to the baseline and what we term as the FRC, the functional residual capacity. So this is what a normal flow volume loop looks like: a positive inspiration and a negative expiration. So the flow volume loops again can be used clinically into numerous things. We can look at the airway obstruction, the bronchodilator response, the air leak, air trapping, what is occurring, we'll just look into it. Okay, so what is this? This is a normal flow volume loop. And what is occurring here? In the expiratory phase, there is a seesaw pattern, undulating pattern. This implies that there is some obstruction, or there are airway secretions in the airway, or there is water in the circuit. So the expiratory limb seesaw pattern implies airway secretions or water in the circuit. Okay. Another one. So what is occurring here? The peak expiratory flow rate has decreased and there is scooping out of the expiratory limb. So what is this basically? This implies there is increased airway resistance. The scooping out of the expiratory limb tells us the airway resistance has increased. So what is occurring here? In this is the inspiratory phase. I always told you that at the starting of the session that inspiration is actually controlled. This is an active thing, but the expiration tells us so many things about the lung mechanics. So here the expiratory limb is not reaching the baseline on the x-axis. So what is this? This much volume has been lost. Again, this is a air leak occurring in the system. So air leak we can look at from the volume times graphic, wherein the expiratory limb, this much amount of air has been lost. From the pressure volume loop, wherein in the expiratory phase, on the baseline was not touched on the y-axis, this much volume was lost. And in the flow volume loop, wherein in the expiratory limb did not touch the baseline on the x-axis, and this much volume was lost. So these are the multiple graphic representations of air leak occurring in the system. Okay, so coming on to another thing. This is a normal flow volume loop, and what is occurring here? Again, the expiratory limb is not reaching the baseline, does not touch the FRC. So on the y-axis. So what is this? This is basically air trapping. This much flow has not returned back. So there has occurred air trapping in the system. Okay. So this was basically what I wanted to cover, the most of the clinical points about the ventilator graphics, because ventilator waveform analysis is certainly an integral component in the management of a mechanically ventilated patient. We ought to develop a habit of looking at the right waveform for the given mode of patient ventilation, and always look at both the inspiratory and the expiratory components. If there is something happening at the inspiratory waveform, that implies that there's some trouble with the ventilator itself. And the expiratory components, they tell us that there's some problem with the lung mechanics. And we have to look at those things and then use them into the clinical management of the patient. And don't hesitate to change the scale or speed of the waveform to aid in your interpretation. Actually, I'll say that once we are versed with the ventilator graphics, they are like magic wands for us. usage of these ventilator graphics. It's wonderful because standing on the patient bedside, understanding the different aspects of ventilation and using them into the clinical management of the patient, that is a wonderful thing. So that certainly makes a lots of difference. As Dr. Sudipta was saying at the beginning of this talk, that yes, weaning is the last thing to happen in the ventilation. We start weaning once we put the patient on ventilation. But yes, we need to learn and we need to look at what is happening with the ventilation. It's not just like starting the ventilation, putting the patient on ventilation and going off to sleep. We have to look at the interface of the ventilator. And I'll really assure you, once you start looking at the ventilator graphics, you'll just enjoy yourself. And it's a wonderful thing to do, right? So I hope I made something clear to all of you. And it was just small because I just wanted to cover just the basic, very basic things, the clinical aspects of ventilator graphics, which we can use day in, day out in our patients. Thank you.
Thank you, Dr. Kanwal, for making such a complicated or difficult things to present in a concise way within 20-25 minutes and make it look so simple. As you mentioned, I fully agree with that. It may appear very difficult to begin with, but once you start using it on your daily practice, and then it becomes an integral part, and gradually you improve your understanding in this regard, and the whole concept start getting better, and it helps you in your regular patient management. Right. We have some
exactly
in your chat question box. Like Dr. Yamini has asked, can you please explain the concept of hysteresis in PV loop?
Basically, hysteresis we look at once we want to look at the compliance things and all those things. Basically, actually, I have to have the graphics around. Let me show it to you. Just a minute, because that will be most easily understandable once we have the things with us. Just a minute, because the graphics cannot be explained just without the links. Just a minute.
Dr. Kanwal, can we go to the next question? I think it is difficult to explain hysteresis.
Yeah, because yes, exactly. This is what I was thinking, because I cannot explain basically without the showing the loop.
If I can just extend Dr. Kanwalpreet's presentation, the information ma'am has said that when you mention about hysteresis, it is the basically difference in energy in the inspiratory and the expiratory limb. So basically the area under the curve, area below the inspiratory limb and the expiratory limb indicate the hysteresis, that is the loss of energy when the patient is getting ventilated. Otherwise, what would happen, the inspiratory limb and expiratory limb would have been overlap with each other. That doesn't happen because there's a loss of energy and it goes in a different pathway. If it is in a simplistic manner, but it's obviously it's a part of a different advanced ventilatory settings, and in regular practice, you may not need it to set your ventilator. And next question is that if you have a double trigger or due to inadequate flow, how to assess in the graphs and how to handle? Again, it's a it is difficult to answer theoretically. These questions seem to answer on the presentation. But yes, these are again not a part of the basic lecture. But if you can just elaborate
So,
a few words.
It's basically like we have to know how to look at the triggers, and then we ought to understand like the trigger sensitivity, it is whether it's a pressure trigger or a flow trigger, and then accordingly we have to modify the triggers. We have to basically increase the sensitivity. Increase the sensitivity means like the ventilator should be able to sense it at a lower level. This is what we need to understand, that if we have set supposedly a figure of 5, a trigger, right? So 5, that means once the patient triggers, he or she will have to reach that 5 level, a pressure of 5. But if we set and then the ventilator will assist. But if we set the trigger at a lower level, like we decrease the trigger to the 2, so then the trigger sensitivity will improve, and the patient will have to make a lesser effort, or the work of breathing will decrease, and then at a lower sensitivity, the ventilator can assist the breath.
I think because of the time constraint, we cannot go through all the questions, but another question which is coming again and again regarding the role of artificial intelligence. Because for the junior doctors in odd hours when the patient is coming, sometimes it is very difficult for them to interpret the ventilatory graphics and adjust the ventilator accordingly. So do you think in the future, maybe in another 4-5 years, we'll have more application of artificial intelligence and closed loop ventilator in our regular practice?
Exactly. Actually, artificial intelligence in all aspects of medical therapies, it is the future. But I'll suggest that yes, it cannot come to the very basic medical therapies. So we ought to understand the graphics. There's no shortcut to it. I cannot say that you just put a patient on ventilator and just think about, yes, okay, in the very high centers, I think as of now, there are not much centers across the world where artificial intelligence is being used for to understand the ventilator graphics. Yes, the higher modes, the very advanced modes, NAVA and all those things, okay. But if we are basically ventilating and sitting at the peripheries, like me, I am into a peripheral region of India, sitting at I'm running a center all alone. But yes, I need to understand even my senior staff, nursing staff can understand the ventilator graphics. They tend to, I always tell them to see what is happening. If there at all something you feel that it's not okay, so you have to deal with it. There are no shortcuts in the field of medicine. Right. We cannot just shift on to artificial intelligence, yes, but certainly it is the future.
Right. Maybe it helps you in certain scenario when there is a very difficult to understand.
Very difficult, yes.
Manual input, a system to give manual input, and the understanding or experience into that machine is always needed. And I think whenever we are going for a closed loop ventilator, at least there should be a scope to intervene by the experienced anesthesiologist or intensivist who are using it. Right. Yes. So by this, I will like to conclude this session. Thank you, Dr. Kanwalpreet.
Thank you. My pleasure.